Great. Thank you so much. And thanks for having us back here. It's excited to be here and to report on the progress. And as Wendy said, it's been since 2021 since we've been working here in the region. And we're looking forward to continuing to see kind of the fruits of all the work that we've been doing here together with all the different organizations and everybody here. Oops, and I just lost there we go. And so my name is Christian Milaster. I'm the founder and CEO of Ingenium Digital Health Advisors, also here. And maybe Kathy, you can just briefly unmute yourselves, and Trevor, so that you pop on the screen and maybe you pop up to the top of the list of Zoom windows is Kathy Latender.
Hi, everyone. I'm Kathy Latender.
And we'll also have here Trevor Cunningham with us, who's been at us from the beginning here on this effort.
Hey, great to meet you all.
Good. And I'll be looking to Kathy and Trevor to see if there's any additional comments to add here to the slides. Feel free to ask any questions here in the chat. I'll be monitoring it. As Wendy said, I'll have a few slides to go over, and then I'll turn it over to Jason Yael to talk about the impact assessment, specifically the baseline assessment. But we can take questions at the end. We can take questions before I hand things over. So really want to serve you, having access to us to ask any clarifying questions or make any additional comments that can help us. I started off with a timeline because, similar to Wendy, COVID through also my memory in for a loop. We started here with telehealth services assessments in 2021, really looking at about a dozen of organizations to see how were they using and utilizing telehealth services, video visits, RPM programs, and the like, telehealth group visits. And so we've done an assessment there, and I have a little bit of a reminder update slide that we presented a while back. And then, as Wendy said, you allocated some funds to really make an impact in the region here to help with the clinical partners to optimize their telehealth use, to maybe pay for some equipment, to then also work with the schools and the libraries and maybe other community access points to bring better access to care to the residents of the four-county region. And so that's the telehealth program optimization work that is currently ongoing. We also then first took out the time to work with NCESD 171, specifically Kathy Moret, who was on the board before, to develop a telehealth strategy for the schools in the region. And then we worked with the team at NCW Libraries, with Tim Dillman predominantly, but also Kim Nair, to develop a library-based teleservices strategy. So actually going beyond telehealth, which I'll also explain here in a minute. And then we kicked off earlier this year the work with Jason and Yael from Laurel Health Advisors to really do impact assessment in 3 different stages. First, the baseline assessment, which Jason will talk about today, then an interim assessment to really see how much progress we've made, and then to guide kind of the last portion of the implementation, so that we can really achieve the outcomes that we were designed to achieve, and make some course correction or identify different focus areas. So we're looking forward to receiving that impact assessment later this year, early next year, to really look at what can we do differently to really make that impact on access to care and improving outcomes in the region. And then we had the good fortune of also John and Wendy and the whole team pulling together a grant application for an extra grant, which allowed us for additional funding, with a little caveat that we have to generate all the value by September 30th. Also an update on that, but this is really great because we now have, we provided all the infrastructure, all the elements in place, and now we actually got to build on that optimization and actually got to do some really cool things here that we've kicked off a few weeks ago, and are now working tirelessly to really bring better, an additional set of services. I also have an example on that. So that's the roadmap here that I'll take you through in our presentation. Starting with the telehealth program assessment, we've leveraged a tool that we've developed a few years back of assessing organizations on the different levels of maturity, going from chaotic, where nobody knows what they're really doing, but everybody has a webcam and a Zoom license, to all the way where it's strategic and transformative, where organizations really are looking at leveraging telehealth, leveraging remote physiological monitoring, all the digital health innovation to bring care to the patients at a distance. So in everything in between. With no surprises here, you had some really great organizations that were at the strategic and integrated level. There were some organizations who definitely were interested in benefiting from more help that we've started working with. We also did, in the meantime, since our last report, 2 more assessments of 2 other organizations, and that's where they fall on the spectrum. And so really, we're excited to actually go back in the organizations that we've worked with and do a post-optimization assessment and see that the organizations we work with, we brought them to the integrated level, which is our goal, because it's the gateway to really looking at telehealth as a strategic tool to grow access to care, to grow the volume, and to attract providers and all of that. So it's becoming increasingly a strategic tool, which the organization that is at this level can assure you here. So then that was the vision statement and mission statement that was created and that we presented back here. Still retained the NCACH nomenclature here for historical purposes. So the mission is to improving health and wellness in the community through telehealth, so that every resident can access easily all the care they need, where they need it, when they need it, in all means, primary and behavioral, dental, chronic, rehab, specialty care. So really, ultimately having an infrastructure where healthcare delivery organizations, as well as the libraries, as well as the schools, and maybe other community access points, will make it easy for residents to take care of their health, to get diagnosed, to get treated, to have preventative care. So that's really the vision. And again, we're wanting to have this baseline, interim, and final assessment to really look at that we're making sure that we're generating the biggest impact for the investment that you're making into telehealth optimization. Wendy mentioned, I've mentioned multiple times, what's novel about this approach here, I think unique in the nation, is that we're not only improving the telehealth capabilities of the interested clinical partners with the FQHCs, behavioral health clinics, critical access hospitals, and rural health clinics, addiction treatment service providers, but we're also focusing on establishing a telehealth services in the communities, going through the schools as access points, the libraries, fire stations without an S there, and girls and boys clubs. So anything that pops up for the providers. And so that really is novel, that there's a systematic approach across the whole region versus one-off solutions between, let's say, a healthcare provider and a school, or between a behavioral health provider and a library, which is what we're seeing in other areas in the US. And so and we're obviously very optimistic that this will produce the impact that we're hoping, so which is why we're looking at that impact assessment. The approach that we're using is very comprehensive based on our experience in the telehealth, telemedicine field over many years. So we're helped all organizations that we're working with to establish their virtual care strategy, telehealth strategy, connected health strategy. Different organizations chose different names for it. But it all started with really engaging the leadership team, the clinical leadership, the executive leadership, and really establishing also a support structure that can help clinicians and staff to deliver telehealth powerfully. That means we need to have workflows and policies well-defined and trained on. We need to have the technology optimized and selected. Most organizations, we just kept them at the technology that they were using, but just optimizing use and the training. And then performance management, another leadership responsibility. How well is our telehealth service actually going? What's the utilization? Is it going up? Is it going down? What's the satisfaction level of patients, of clinicians? So really a systematic way for each organization to assess how well they're doing with telehealth and telemedicine. that all hinges on ultimately on the clinician engagement. Ultimately, it's the clinicians that need to decide whether telehealth is a right tool in the tool chest of a clinician to deliver care. And last but not least, we need to let people know that this is an option now internally as well as externally. So we're also working then with the leadership team and the governance team to establish an internal and external marketing strategy. So that's our approach. This is a snapshot from some updates that we are doing with steering teams where we're tracking kind of the different lines here in the project management Gantt chart to just describe progress as we're moving through this over the course of multiple months to really make sure that we're hitting all these 7 elements of this approach. Switching gears now to the other side of that diagram of the multi-pronged approach, starting with the school and library strategy. Basically, there's 5 different themes that emerged. One, it was important for both NCESD as well as NCW libraries that our strategy prioritizes those schools and those regions in the area that have the highest needs. So in our prioritization efforts, given that there's limited amount of funds to roll it out to all the schools, so starting with some schools, where can we address the highest needs? And also that we're leveraging a systematic coordinated approach so that not each and every school figures out things on their own and what works for them, but through the continuity of working through us here, we're developing a playbook. We're developing the best practices of establishing school-based telehealth services, establishing the best moves to establish telehealth in a library. And there's nuances and differences given on the community and the dynamics or the staffing or the size of the school. And we're documenting all of that in a playbook so that when the funding that Thriving Together has provided reaches the end and we've rolled it out to, let's say, 10 or 12 different schools and libraries, then NCSD as well as NCW libraries have a playbook that they can use to then continue the rollout, leveraging the best practices that we've discovered and documented and followed during our rollout of this. So that's how we're doing that. And then the first step is to establish the access points, and then on top of the access points, then facilitate and project manage the launch of different services. So we're in the middle of that. We're looking at a number of schools and libraries to establish the access points. The equipment has been ordered, or in one case already received. It will be installed here within the next few weeks, and we'll be able to kick off behavioral health services in schools and in libraries here over the next couple of months. And then we're not going to stop there, but we're also going to want to make sure, similar to that performance management mindset that I described earlier, that we are continuing to optimize utilization. One of the things that we've seen as we've studied school-based and library-based services around the country is that it's a build it and they will come approach, or set it and forget it approach. And so we really want to leave both the leadership teams, both at NCSD and NCW libraries, with an easy to look at a dashboard where they can track utilization and intervene if utilization goes down or it doesn't go up. So obviously we'll be still involved here in the next months as we roll this out so that we can identify best practices to increase utilization, because most of this is going to be a lack of awareness. So we'll be also included in this is raising the awareness in the communities as we're launching these telehealth services, especially when we're going into the public spaces like a library, to really let the community as a whole know that this is now something that the residents in the community can use to use video visits if they don't have the capability at home with their care providers. And so that is really the long-term vision, but this all also hinges on optimizing utilization by measuring utilization and then acting on the data. Good, and let me just see here, good. So the novel approach also here is that, as I said, we don't have just one health center, one behavioral health agencies establishing school-based behavioral health or library-based primary care services, but we're establishing a telehealth access points that is provider agnostic, meaning that we can have a clinical partner that offers behavioral health services, maybe at this school or library. And we have a second clinical partner that can, where patients can schedule also primary care video visits. And we could envision that we also have clinical partners that maybe that offer specialty care services, as well as then the first clinical partner could also maybe offer primary care services. So it's a shared resource. It's a, if you want to call it a video booth, we could call it like that, although it's not a booth in most cases, but it's an access point that is accessible through a shared resource. And so as we grow this, basically the bottleneck is to letting everybody know how to schedule this particular resource for a visit with a patient. But that is the idea. Our focus at this stage, anchored in both strategies, is that we're focusing on the regional providers here in the 4-county region, but we also know of patients, of students who are traveling long miles to Spokane or to Seattle to see a specialty care provider because they don't have the telehealth capabilities at home. And so these down the road may also provide additional opportunities to see a child psychologist or to see a pediatric cardiologist at specialty care providers outside of the area. So really, it's an investment in an infrastructure that helps to build access to care in the region. The schools, you're familiar with your map here. So there's the different about 30 school districts and 150 schools. And where the technology we're installing is again, it's telehealth solution agnostic. So basically it's a computer, and whether we install Zoom in it or Doxy.me or Covio or other specialty care platforms, that can be installed on the computer. But it's not prescriptive, meaning a provider who wants to provide services to students or to patrons or residents in the area is not limited to using that technology. It's their technology that their clinicians are already used to. So a very pragmatic approach. Similar to the libraries, we have a lot of libraries, and between the libraries and school, we really are getting up into a lot of the different pockets where access to care is tricky and challenging, where the driving times to the nearest provider is difficult. And so that's where we're also prioritizing them on looking to establish access points to really address the highest needs first. But we're not stopping for libraries at telehealth services, but really looking at here the 7 vital conditions and looking at what other services that do patients or do residents need in order to maintain their wellness, to restore the wellness, to live well. And as we know, there are several factors that are impacting health. And so we've been looking, and this is just a brainstorm, to establish relationships with the social services agencies that are already set up to do a video visit, but residents in the area don't have access to it because they don't have the technology or digital literacy or the data plan to support it. And so here the idea is that you could schedule your visit at your local library in order to receive that social services, again, looking at the more comprehensive approach that Thriving Together has set forth in its vision to really improve health and wellness in the region. And just in case you were curious who's on our roadmap here, so these are the 6 schools that we're currently talking to in the first phase. So we're in Chelan, Douglas, and Grant County right now for the schools. And then we're also looking at libraries in Chelan and Okanagan County. So really covering a whole area here already in this first phase. There are some providers here that are already providing services to schools. So some of the schools are already served through primary care and behavioral health. And so we're just looking especially at those schools who would have a gap in access to care. And so I'm very excited about having some very rural ones with Waterville. I mean, everything's rural, but Waterville and Wilson Creek, I think, are a different level of rurality. And so very excited that we're having the superintendents being super excited to bring this particular service. And we're working with the counselors there. We're working with the school nurses through Kathy Moret to really build the buy-in in the organizations and helping them to make this as easy as possible, because schools and libraries are always very, very busy places. So we're optimizing it for their time as well. And then last slide here, before I hand it over to Jason, is just a sample of what that investment in the structure and in the telehealth optimization allowed us to pull together in a matter of a few weeks of really brainstorming together with the clinical partners that we've been working with for ideas on how we can improve, expand access to care through telehealth, which was kind of the defined scope of this expansion grant that we have access to through September 30th. One of the very obvious scenarios that we had talked about multiple times was converting no-shows and cancellations to video visits. If the no-show or cancellation is because somebody forgot or somebody doesn't have the time to travel, can we convert it into a telehealth visit? Multiple benefits there. We're looking on the behavioral health side on telecrisis, that is behavioral health services beamed into the emergency room to intervene in the case of a crisis, to make sure what is the best disposition for the patient in crisis. How can we best help this patient? So rather than having to travel to the ED, being able to do this remotely. Offering more substance use disorder treatment services to residents that would otherwise have to travel 45 minutes to an hour and a half to participate in group sessions, and then also looking at the outlying areas. How can we do remote intake services for one of the clinical partners we're working with? On the medical side, then we're looking also at remote physiological monitoring for chronic care management with one of the critical access hospitals. We're looking at inpatient telespecialty care, virtual therapy for inpatient care, as well as tele-addiction treatment services and for inpatients to get that started before they're being dismissed. So alcohol or substance use disorder treatment. So really looking at really leveraging this infrastructure and that expertise that these clinical partners have now gained to deliver care at a distance, to really leverage that to open up the services to more individuals and provide better care. And then on the other side here of the school-based and library-based, we're looking at telebehavior health to students in 3+ schools, tele-addiction treatment services in 1 to 2 schools, televisits to library in 1 to 2 libraries, and then also starting the process of telesocial services. And all of that we're working on, not aiming for, but we will deliver all of these services by September 30th. And it's thanks to the investment in all the work that went beforehand in building the relationships that allowed us to really be confident that we can move this quickly to establish these types of services. So very, if I may say so, very rewarding engagement. So good. So here was our roadmap that I've talked about. And again, happy to answer questions that come up here, and we also have some time for Q&A after Jason's presentation here. So worked on those 4 areas, and now it is my pleasure to hand it over here to Jason Goldwater and have him talk about the baseline assessment and the framework for advancing telehealth.
Right. Yael, do you want to go ahead and go? Can everybody see the screen? I lose it.
I can share my screen once I figure out where the chair is. There it is. I cannot share. I don't have permission. Sorry.
Okay, Yael, I just made co-host.
Thank you so much. All right. So hopefully you see my slides now.
Yep.
I am not going to put it in presentation mode because for some reason it likes to hear what I say and then type what I say at the bottom and everyone else sees it, which is a little embarrassing. So I will go through the slides and then I will turn it over to Jason. So Jason and I are, I'm the CEO and Jason's the president and COO of Laurel Health Advisors. And Jenny was kind enough to bring us on to this project to work with Wendy, and it's been a true pleasure. to help understand the baseline of what's going on within the community so that we'll frame the next steps of our impact assessment. So going here. Just go this way. So the purpose was really twofold. One was to understand the use and potential for use of telehealth across the region. And then the other was also to develop a framework that would be used to inform an interim assessment moving forward of the progress being made based on the investments that Driving Together has been making in the community, as well as Ingenium's efforts that you just heard about. So we started with a set of research questions to guide the decision, to guide our focus. And we really wanted to understand why people used telehealth. What are they hoping to get out of telehealth? Or why are they not happy with telehealth? Why maybe they have started using telehealth, decide not to continue using it, or they've been trepidatious about beginning to use telehealth. We also want to understand how telehealth is being used. What are the conditions it's being used to treat? And then is it really being helpful? So effective in terms of better quality, in terms of meeting the patient's needs, in terms of care coordination. And then we wanted to be objective in terms of the cost. How is this impacting total costs? And that is cost to the patients and cost to providers and cost to the community and the insurers. And finally, to understand what the barriers and obstacles are so that Ingenium can shape their work around addressing this. So quickly of the methods, what we did was we got publicly available data that's out there, for example, the US Census and Washington Department of Health. But we also were fortunate enough to have someone in the State Department of Health run us some data on your state's all-payer claims database, which gave us some rich data. We also, thanks to Wendy, identified over 30 stakeholders from across the community who spent, including some of you, so thank you, who spent time speaking with us and sharing their insights. So this included providers, payers, community-based organizations, and then the others category, as you can see, is quite diverse. So a lot of representation, a lot of perspectives, which were incredibly insightful. We also did a quick survey of some health systems to understand how they're using telehealth. Some of this had already been done by Ingenium, but a few had not responded. So we then reached out to those additional ones. And so we had a full cadre of everyone who's responded. And we also looked at what the literature is out there, especially as related to how do you assess the cost and the impact of telehealth. So this is a quick assessment of the availability of services in the county. This was done, basically, I looked at all the HRSA data for FQHCs. I looked at Washington State Department of Health for hospital data, and then a search of other sources such as behavioral health and individual provider websites, different health systems in the area. And so as you can see, there's quite a few FQHCs out there, but they're not evenly distributed. As far as behavioral health, there are no behavioral health clinics in Okanagan and Douglas. That's worth noting. And so it gives you kind of a perspective of what's available and what's not, based on what we could find. Now, behavioral health, I want to point out, these are not standalone clinics. So there may be some associated with the FQHCs that are not standalone, which is not, these are standalone clinics that are not affiliated with anything else. And these could be substance abuse clinics, et cetera. We also looked at what were the primary diagnoses. So for telehealth, we found the primary diagnoses were actually anticoagulant use, and then depression, stress, and general anxiety disorder, which is very close to, we see a lot of mental health across the nation. However, when you looked at the in-person visits, we saw something very different. We saw hypertension being the #1, then anticoagulants, so that fits there, but then diabetes, which was all the way down here, was the next. So we found some distinct differences, and that's worth noting because telehealth is not always the best fit for every single service. And so trying to understand, is telehealth being used for the right services? And if there are services that it could be used for, whether we should optimize their use. So let's look at the primary, let's go to the stakeholder feedback. So the key things is that stakeholders feel that telehealth has increased accessibility. It's also, they also said that adoption continues to remain a problem for a variety of reasons, whether it's broadband barriers, whether it's ownership of device, whether it's the cost of internet. everyone really agreed that telehealth is well suited for behavioral health as well as chronic disease. Although some people said it's been a lifesaver if they have a chronic disease that they don't have to go to the specialist and travel to, for example, the cardiologist. There's been a lot of concern about the uncertainty of reimbursement. So providers have suggested that they'd like to make more investments in telehealth and expand their telehealth work, but they don't want to invest more in a platform if it's not going to be reimbursed, especially because a lot of providers are in community health centers where Medicaid reimbursement would be critical to their continued operations. Hybrid care, everyone seemed, that's what we call in-person and virtual, was really well welcomed. People thought it was an excellent way of combining that some visits need to be in person, but a lot of visits can be managed via telehealth. One example of that, people said maternal health care, that there's, a lot of challenges in terms of, especially if you're a high-risk pregnancy, getting to care, but being able to use telehealth when in between visits to track things and communicate with your provider is great, as well as after birth. Telehealth was a really wonderful in terms of postpartum depression, lactation consultant. So really supporting the community when they can't get up to specialists. They also talked about the need for more education. So education being people don't even realize telehealth is available in the community or what it can be used for. They're not aware their provider even offers telehealth. And then, of course, there's a lot of challenges such as digital literacy, not knowing how to use technology. And so that is a program that is already being spearheaded by Thriving Together to help really expand that work and increase digital navigation skills among individuals in the community. And they all agreed that telehealth had real potential to reduce health disparities, increasing access to a wide array of populations, everything from tribal community members to single parent households to families on family assistance, medical assistance programs. And then what we did with the survey is we found that almost everyone said that they were using it for behavioral health unless they didn't offer behavioral health. So if behavioral health services were offered by this health system, they are using it for behavioral health, but they're also using it for specialty care. And a lot of them found that case management was a really valuable way of using telehealth. They told us about examples of better care coordination, better medication management, lower rates of no-shows. So a lot of value in using telehealth for disease management. But they did point out that a lot of patients use audio-only telehealth. The being is the either A, not having access to a digital device or a broadband, or not really being tech savvy. And this is actually a barrier for older adults because a lot of them still use flip phones. So even if you make audio-only telehealth available to them, they still don't have a way to connect to a telehealth visit, which is why the community-based situations that Christian described will be essential. And as I mentioned, the key barriers are actually having access to technology, and then connectivity, and then broadband availability. And it's worth noting that even in places, some areas, there was no cell phone connectivity. So that was a real barrier in that if you didn't have a form of transportation, you still had to get somewhere just to connect to a telehealth visit. And so we looked at what public transportation and other features were out there to help meet that need. And I'm going to turn this over to Jason now to discuss the impacts on cost and our final findings.
Good afternoon, everybody. It's great to be speaking with all of you and to see some of you again. As Yael mentioned earlier, my name is Jason Goldwater. I'm the President and Chief Operating Officer here at Laurel Health Advisors, and I was responsible for the somewhat, I guess, involved economic and quantitative analysis, or as people like to refer to it, the not so sexy version of the baseline assessment. But what we did do is we looked at both the cost benefit and the cost effectiveness of telehealth services up to date, and then established a framework to continue the analysis as we move forward with the impact assessment. So the first part of this was the cost benefit of telehealth. And Yael and I have been involved with this work for a number of years, and we've done this not just here at Thriving Together, but we've also done it nationally. And we developed a framework and a methodology to be looking at cost benefits. And to do that, obviously, you have to break down what the cost and what the savings would be. So the costs that are generally associated with telehealth that we factored into our model are the cost of personnel, the physicians, the nurses, the nurse practitioners, and those that are maintaining the system. the cost of overall broadband services, which fortunately we were able to find in a number of sources throughout Washington State, the maintenance cost associated with telehealth equipment, and then the overall cost of operations. The savings that are attributable to telehealth, now taking into account that usually when you're evaluating the economics of telehealth, it's not really just a straight comparison between telehealth and in-person care. It really is, you're looking at the ability of telehealth to provide care where otherwise care would not have been provided. So because of that, you look in terms of savings at reduction in hospitalizations because somebody would be able to access care at a particular moment in time. Now, the literature throughout the years has really documented different percentages to be taken care of. And what that means is that when you factor in a model, people will look at a 50% reduction in hospitalizations, a 75% reduction, or so forth. In our model, we used a 10% reduction, which some people would say is low. But typically, when we do this analysis, we look at the most conservative estimate possible, really to try to get an understanding of what those savings would be in a very objective and non-biased manner. We also look at reductions in travel, that obviously the use of telehealth means the patient does not have to travel to an in-person site, and then increased patient productivity. And what that means is a patient does not have to take time away from work. They do not have to leave their job for a prolonged period of time to be able to travel to go see a provider and then have to travel back. And for many of the individuals within the counties that we were studying, a lot of them have hourly wage-based jobs, so that would be a significant detriment to actually be looking for in-person services. So keeping that in mind, we factored all of these and looked at what the overall savings would be. Now, there's a lot of different elements that we could look at, but when Yael showed you where telehealth was being used the most in our initial analysis, we took those into account to figure out what the total savings would be in the different counties. And as you can see, when you're factoring in the savings from reduction in hospitalizations, reductions in travel, increased productivity, even by the counting the cost of telehealth, that the overall savings in the baseline assessment are fairly significant in the millions of dollars. This is not anything that is unusual. This is very similar to other findings that we have uncovered during our research, and it is predominant in areas in which there are large rural populations. In very close or in very dense population-centric areas, the savings would not be as realized as they are here. And that's largely because in-person providers are fairly not far away enough in which telehealth is a necessity. Telehealth at that point becomes more of a convenience. In areas that are generally very rural, telehealth becomes slightly more of a necessity, so the savings are more acutely realized. So in all of these, particularly in areas of heart disease, and especially in the areas of mental and behavioral health, you can see that the total cost savings is fairly significant, as well as hypertension, which is important as it's something telehealth is being used for rather frequently, because people that are often hypertensive, as many of you know, generally have other conditions that are being caused as a result of that hypertension. So being able to control that through the use of telehealth provides not just a financial benefit, but also a clinical one as well. So the cost effectiveness, so this is slightly a different approach. So what we look at cost effectiveness is, if you look at two ways of comparing care, which one leads to an outcome that is more effective overall, and the one that is not effective, how much does that have to be increased in order to reach that same outcome? Now, based on the information that we received through a lot of the stakeholder interviews, as well as just sort of the general trend of the field at the moment, is that many people are now considering telehealth to be incorporated with in-person care and formulating a hybrid model. So that is, telehealth is used as an adjunct to in-person care. It doesn't replace in-person care, it was never intended to, but it is part of the ability to receive care in addition to in-person visits, which are essential. So we looked at two specific areas in which we were able to gather quite a bit of pricing information from Washington State. And we looked at people that have co-occurring conditions. So the first one was diabetes and major depressive disorder. This is also pretty common, that people that generally have a chronic disease overall also have generally some mental health issue going as well. And then the other one was looking at substance use disorder as well as co-occurring serious mental illness. And serious mental illness is generally defined as a type 1 access mental health disorder. So schizophrenia, bipolar disorder, major depressive disorder, etc. And when we factored this in, you can see that in-person care generally costs more overall. But what was more important is that in both of these cases, the quality adjusted life years, which is how much would an individual's life be extended if they were to use a hybrid form of care or in-person care, and how much would that cost to have an equal effect. In both of these cases, the quality adjusted life years was pretty much the same. There are some differences, but we would consider these to be marginal. However, what is critical to look at is that in both of those cases, it costs slightly more for an in-person visit to reach that same outcome. So even though the quality adjusted life years are fairly similar, in-person care costs slightly more to reach that same level. The last one we looked at was critical care and teleneonatology, also something that is very predominant, particularly in rural areas. And what we looked at is the ability to be leveraging telehealth in an inpatient setting to access a neurologist or a neonatologist rather, to be able to provide a consult to determine the next step, rather than immediately going to an emergency room and receiving care that way, or being transferred to some place to be able to provide critical care because they were unable to do triage in the beginning. And what you can see here is that doing a teleneonatal consult is significantly cheaper than it would be for the standard of care, and that the incremental value to achieve that same outcome really is significant. So we found really that the use of hybrid or in-person care is pretty similar with these co-occurring conditions, with the exception that in-person care costs slightly more. But when it came to neonatology, the significance was fairly acute. So that leaves us to our recommendations. So some of the key recommendations that we really were able to gather through all of this analysis, both qualitative and quantitative, is really to enhance outreach and communication between patients and providers, to educate and train both providers and patients on telehealth to increase acceptance and consistent use, to develop a telehealth services map to help patients locate where they can access telehealth services, to establish partnerships with outside entities that would help support adoption, and then really to use the data to drive adoption by targeting specific patient groups, really showing people if they have substance use disorder and they're struggling with mental illness, where the benefits of telehealth may be. Next slide. Other recommendations to educate health insurers on the impact of high copayments, ensure outreach efforts, demystify telehealth. I would say that's something that's been pretty consistent over the last few years. One of my favorite quotes, and Christian and Kathy both know this, is that I often say telehealth is not a unicorn, that a unicorn is a mythical creature. I'm sorry if that disappoints some people, but it isn't real. So telehealth is not some fantastical form of care. It is healthcare just delivered through another medium. Again, encouraging patients to request telehealth if it's appropriate and convenient, offer support to providers new or with limited experience using telehealth, for data use, really to understand the impact of telehealth economically and socially and clinically, is to leverage data from managed care organizations or use EHR data to target technical assistance. For policy changes, to establish permanent reimbursement parity between in-person and telehealth, to give higher reimbursement for rural health clinics, that telehealth can be provided to patients in non-medical locations. Right now, that's temporary because of the public health emergency. To provide reimbursement for audio-only telehealth, to make community-based investments, which is already happening, but to expand that. Understand that there are privacy issues, particularly when it comes to mental and behavioral health, but understand that you can create a HIPAA-compliant private engagement, but also make it accessible. And then, of course, cross-state licensure, particularly with individuals that would be able to provide services to Washington State, particularly within your region, if they had the ability to practice without hesitation or limitation, rather. In terms of ad hoc recommendations, partner with outside health entities that can address provider shortages, use telehealth to help providers meet educational requirements through continuing medical education, increase provider skills, and reduce costly transfers by facilitating telehealth adoption in long-term care as well as correctional facilities. Next slide. So the interim assessment is what's next. We'll start working on that, and hopefully we'll have some results to share by the end of the year, and we'll finish it by early next year. But that's really to understand how telehealth implementation and utilization affect access to care. How does telehealth affect clinical outcomes? Will telehealth reduce health disparities, increase access for underserved populations? And then can the use of telehealth in value-based programs lead to sufficient savings to incentivize and accelerate innovation? And again, Yael and I have worked in all of these areas. So we have done analysis, we have models, we're just working on gathering the data to really objectively understand what telehealth can, and honestly, what it will not be able to do, but would be able to address these questions and provide greater insight to help guide you further into the future. Next slide. So I thank you all very much for the time. I'll echo Yael's sentiments. We both are very grateful to Christian, Trevor, and Kathy for the opportunity to work with you. And we are just thrilled and very honored to be part of this project. We've been involved in rural health for 4 decades amongst the two of us. So this project is really plays to our passion and plays to the things that we care most importantly about. So we're grateful for the opportunity. Thank you all very much.